Life is said to be a health journey that for some starts by being born with a rare genetic disorder. Now, there are more than 7,000 rare diseases affecting over 350 million people worldwide. And in South Africa, there are 3.7 million people living with a rare disease or other. Now, sadly, 30% of children affected die before reaching their 5th birthday. Now, Rare Diseases Day is celebrated on the 29th of February. And people around the world are joining the global movement for rare diseases by taking part in the hashtag Reframe Rare campaign, holding events and raising awareness. So our topic for today is rare diseases. And to help us understand this condition better is a guest panel comprised of a neurosurgeon, an ophthalmologist, founder and CEO of Rare Diseases South Africa, and 2 women living with a condition called Idiopathic Intracranial Hypertension, or simply IIH. And one of them is also the ambassador for Rare Diseases South Africa, and the other one will join us via Skype from a hospital. Now, both of these ladies will share their personal experiences of living with this condition, IIH. Now, be part of the show by asking the panel some questions or simply just sharing your views with us. The number to call is Johannesburg 714-5861 or 5877. You can also tweet us at SABC Health Talk or simply just interact with us on our Facebook page, SABC Health Talk. So sit back, relax, and learn from this bumper show coming to you just after a short break. I'm Dr. Sello Daung, and this is Health Talk.
Public Protector Mosisiwe Mkhwebane's fitness to hold office is currently under question.
It's about the comments that was made by the court. Istina matter. She didn't investigate that matter at all.
Advocate Thuli Madonsela has previously said that she doesn't want Ms. Mkhwebane to be judged on the work that she did. We can't get away from that inevitability, can we?
I mean, I think she's being judged on her performance in office and the number of cases that have been taken on review that she has lost. She keeps challenging and appealing these decisions and keeps losing in all of the courts in the country. And it is on that basis that she's being judged.
She made it possible. I would not have wanted her to be judged that way. Let's be fair to her. Let the process not only be fair, but be seen to be fair. And let her just calm down and chill and allow this process to run its course.
Taking a look at how the youth consume news.
I prefer using social networks for information.
I happen to find reading news on my cell phone more convenient than reading news in newspapers.
I do follow various news sites there, and I get the links to their news articles that I read every single day.
I prefer using the net to watch to get the news because of it's convenient.
Watch Media Monitor Sundays at 9 a.m.
All right, so we're going to be talking about the concept of rare diseases, and to help us take us through this, it's a great pleasure to welcome our special guests for today. The first one, a gentleman sitting on the chair, is Dr. Khomotso Hlahla. Now, Dr. Hlahla is a specialist neurosurgeon based at Unitas Hospital. Welcome to Health Talk, Dr. Hlahla.
Thank you very much.
All right, and then the lady in the middle is Mareike Thompson, who is ambassador for Rare Diseases South Africa, and herself lives with some rare condition that I referred to earlier called IIH. Welcome to Health Talk, Mareike.
Thank you very much, Doctor. It's an honor to be here.
Right, and last but not least, we have Kelly du Plessis. Now, Kelly is the founder and CEO of that organization that we referred to earlier, Rare Diseases South Africa. Welcome to Health Talk, Kelly.
Thanks very much for having me.
Right, perhaps let's stay with you. And let's just define this and put things into perspective. When we say rare diseases, what exactly are we talking about?
So technically speaking, a rare disease is defined as a disease that impacts one person in 2,000 live births.
Right.
So, I mean, that doesn't seem too big a problem. 1 in 2,000 is really, not that rare, really.
Right.
But some of them affect one family in the entire globe.
Yeah.
So they are ultra rare conditions.
Right.
So that's the global definition. In South Africa, we have adopted 1 in 2,000 as well.
Okay.
So if you look at the prevalence of that, based on our country's population, we should have an estimated 3.7 million South Africans impacted.
All right. So let's again put things into perspective. When you say an individual condition is rare, I mean, you've just quoted the figure of 1 in 2,000, correct?
Okay.
So what's the big deal? Why should we create this awareness around one very rare condition?
So that is exactly the problem. So individually we're very rare, but collectively we're common. And collectively, when you consider 3.7 million South Africans, it's 3.7 million South Africans battling to access any healthcare services because their conditions are not recognized anywhere. So a concerted effort is required to be able to actually define, quantify, and provide a treatment plan for these patients and allow them to access their constitutional right, which at the moment is not happening. So we're the shunned patients of society. We often referred to as orphan diseases because that's essentially what you feel like as an orphan.
All right. Mareke, tell us about yourself and the organization. I mean, you play the role of ambassador for Rare Disease South Africa. Just tell us a little bit about what that entails.
Okay, I'm mainly focused on support with patients, being the voice between Rare Diseases South Africa and our IIH community. Because the problem at the end of the day is the support and knowing that there's an organization that's standing up for you, that is making your voice heard. But if you take Kelly and Rare Diseases South Africa and the people that is working for Rare Diseases South Africa, how do you get to play a role with all the patients? So in the different types of rare diseases that Kelly will refer to later, is IIH support one of my main things. And emotional support, motivation to help those patients get up. Sometimes you wake up in the mornings and a motivational message or something on the group will help to make that person feel better. So we are the support system and the voice between the patients and Rare Diseases South Africa.
So is it only about just patients with or people living with rare diseases and nobody else?
No, and their families, and also we provide a fair amount of support to the healthcare professionals supporting these patients, because it's an enigma for them too as doctors and healthcare practitioners. They're sitting with people in front of them that they've never heard of the condition themselves, and I mean it's a known thing that often your doctor jumps onto the internet to see what it is that it could be. So we provide a fair amount of support and providing them with networking and referral systems to international doctors, etc., or other doctors within South Africa who are treating a similar condition.
How old is the organization?
We are 7 years old now.
Okay, and what prompted formation of this? You're the founder of the organization. What prompted you?
So my son, it was born from personal necessity. My son was diagnosed with a very rare condition called Pompe Disease when he was 11 months old. And I remember our doctor at the time, I said to him, okay, so where do I sign up? I had a friend who had been diagnosed with diabetes, and they came home with 1 million pamphlets and, like a chronic care book. And I was like, okay, so do I get some information? And he said to me, it's not one of those diseases. And I realized then that we were on a very isolated road. And I made the promise that if we were going to have to go through this, I was going to have to turn the pain and bitterness I was feeling into something bigger than that. So I wanted to start trying to help other families, and even if it's just knowing that there's one other person out there that's going through something similar, it makes you feel a lot better.
All right, I'm going to come back and ask you how big the organization is, but let's just get a perspective from a medical professional. Dr. Sasha, we've been talking about rare conditions here, and we've just had an example of Pompe disease. In your experience, I mean, how often do you come across rare conditions? And perhaps you might have a few examples that you might want to share with us.
Okay. So as a specialist, you end up having to get those rare conditions being a little bit more common as a specialist because you're a subspecialist from that. But as a general practitioner, I'm sure they must be extremely rare from that. So I'm going to mention a couple of conditions. One of them is not that rare, and this is a tumor, Pituitary Adenomas from that. Those are relatively rare tumors, but as a specialist, particularly with an interest of those conditions, you end up seeing those. They account for about 10, at most 15% of all CNS tumors from that. So those tumors are relatively rare, but as a specialist, I get to see a little bit more from that. And you have other tumor examples like craniopharyngiomas, those are extremely rare, and you end up seeing less of those soon.
So it's quite an interesting point that, you as a specialist then tend to be the one that actually sees these conditions.
Yes.
But let's talk about diagnosis now and the level of knowledge of these conditions. I mean, the more rare the condition, I would imagine, the less is known about it, and the more the likelihood of it being missed. Your comment on that?
Yes, so on average, this is about a global average. It takes around about 4 to 5 years to diagnose a rare condition. And where now that is literature from well-resourced areas. Now, in African context where we have difficulty in accessing healthcare and lack of specialities from that, you can only start to imagine how long it will actually take to diagnose one of those rare conditions from that. So speaking from the clinical point of view, it is obviously a huge problem and a huge obstacle, as some of these patients are diagnosed late. Right. And we'll come to that, is that these conditions, majority of them don't actually have treatment or cure. Right. They don't. And it is quite important to diagnose it earlier because you can have a significant impact on the quality of life. So now you end up with a delayed diagnosis, lack of access to health care, and so you end up with patients that have a very poor living circumstances or quality of life because it is diagnosed late. They have obstacles in getting diagnosis and getting specialists with an interest of that, and also achieve or obtaining health care. So that is a significant problem in our African context, particularly in South Africa as well. Right. It's lack of expertise and also access.
Okay. So Marike, you have a condition called IIH.
That's correct.
Idiopathic Intracranial Hypertension.
Yes.
It's so rare I can't even say it. All right. We're going to take a quick break. When we come back, now we're going to focus exactly on that condition, IIH. Please stay with us.
I'm not justifying apartheid in any way whatsoever.
But why can't you agree with that? Because it wreaked havoc to millions of South Africans.
It did, and I apologize for that.
He actually did not know that there's a convention declaring apartheid a crime against humanity.
The General Assembly labeled apartheid as a crime against humanity.
There's a difference between calling something a crime. Like genocide is a crime. Apartheid cannot be compared with genocide.
He was making a very narrow comment.
It's not only a crime against humanity, it's actually a sin.
It's an unrepentant apologist of apartheid who is not willing to accept that apartheid was crime against humanity.
I profusely apologize for that.
The World Health Organization has urged countries to make preparations to deal with possible cases of the coronavirus.
China's new confirmed infections from the coronavirus outbreak increased by a daily record to top 14,000.
These 213 people have died from the virus in China.
There are now around 17,500 confirmed cases of infections and over 360 deaths.
The mask that you wear that in fact carries the biggest protection you have.
Countries rapidly respond to the virus by shutting down their borders to China.
2,000 people are being kept under observation in Kerala in hospitals and homes.
Imagine not being able to enjoy life's most precious gift, your eyesight, not being able to read or see things. That was almost Refula Siseko's reality. Ambitious to start her own logistics company, mother of one from Pimville, Soweto, is living with a rare eye condition called IH. She describes how and when she started developing symptoms.
It started around 2017. I was a tutor online at that time, and I had a headache. So at that particular time, I just thought it was, okay, it's one of those migraines because my father has a lot of headaches. So I thought maybe I just got it from him. I let it off. I think 4 or 3 days later, the headache hit again. So with the headache, it hit my right eye. So it felt like I had a cataract.
While the symptoms persisted, she then went to see an eye specialist, who then couldn't help as IH is hard to diagnose at first glance.
My vision became worse, so the clouds started to spread out. I told him the same thing again, my optometrist, but he still couldn't see anything. So he just automatically said, I don't know what's going on, I'm sorry, I cannot help you.
IH forced Refilwe to resign from work and stay at home. Months later, after numerous visits to the doctor, she finally got diagnosed.
The 8th doctor, and I met that neurologist through my therapist. And she diagnosed me in 2018 when I was about to return back to work, to doing day shift. She is the one that diagnosed me with IH. Yeah, she reminds me.
After getting the news that she is living with IH, Refilwe was shattered and couldn't understand how and why.
I was angry, I was upset, confused, and still not understanding as to how did it start. I don't understand.
The most common type of surgery performed for IH is the insertion of a shunt. Refilwe is due for that operation, and the procedure makes her skeptical.
I'm nervous to do this operation. Some might say that my operation will be for an hour and a half, so says my neurosurgeon. For other people, it's like, okay, no, it's just like an hour and a half. But for me, I haven't been to any type of surgery in my life to that extent of me being on a table for an hour and a half. Obviously, the first thing that comes to mind is, will I come back from that?
Well, welcome back. So we're going to be talking about that condition, IIH, and it's a great pleasure again to welcome our other guest, Dr. Rob Daniel, who's a specialist ophthalmologist based at the Senton Eye Clinic. Welcome to Health Talk.
Thank you very much, sir.
Right. And of course, we still have Dr. Sasa, who's a neurosurgeon based at Unitas Hospital. So, gentlemen, let's talk about this condition now. First of all, I think we accept that it is rare. How rare is it, by the way?
Well, IIH, or Idiopathic Intracranial Hypertension, accounts for at most 28 per 100,000 people.
Yeah.
So per population from that. So it is quite rare. Right. You don't have a lot of literature in terms of epidemiology-wise from in the African context, but internationally that's about it from there.
Right.
So it's not common.
So how much is known about the condition then?
Well, pretty not that a lot from that. For example, as you take it from the word itself, idiopathic. Idiopathic is taken from the Greek term idios and pathos, basically means one's own. So
well,
idiopathic.
Some people say the idiots don't know the pathology.
Exactly right. So in current medical terms, it means we don't know what the cause is. Idiopathic. So we don't know what the cause is. There's a lot of pathophysiology that is postulated behind the cause of that, but we still don't know from that. That's why it is subclassified into primary and secondary, because primary means we really don't know. While secondary, it means there is something causing it. We need to investigate further. And so there are a lot of other causes, secondary causes.
So let's stay on it before we talk causes then. How does it actually develop? What actually happens in there?
Okay. So essentially what it is, as the word says, intracranial hypertension, you start developing raised intracranial pressure. And we don't know what the cause is from that. So because of raised intracranial pressure, it affects a lot of things. One of that is the cranial space is a limited space. As the pressure rises, you start having headaches. So that's the most common presenting complaint. But the eye, the visual apparatus is connected. Everything is connected. It's one system. The pressure starts spreading out, and it involves the eye from there.
Talk about the eye. Dr. Daniel, I mean, how often do you get to see, well, we can't say how often, but you may have come across this kind of condition. Just give us a sense of your experience with this condition.
Interestingly, I probably see about 2 patients a week with this condition.
Is that it?
And that's because we're referral centers. So these patients are picked up and then we're pretty much the end of the line. Primarily, I think the most important thing to remember is that when you have, a lot of people have headaches, but visual symptoms then really need to be addressed. So the function of the optometrist would be to, if they cannot correct the vision with glasses, they would then refer the patients in to us as ophthalmologists, and we'd refer to our neurosurgical colleagues.
Okay, so coming back to the symptoms, I mean, we mentioned headache. So the visual symptoms, what exactly is it? Difficulty in seeing, or is it pain around the eye? What exactly do they experience?
Yes. So it's quite a nebulous thing, because often what happens is that, the pathology or the cause of the problem is the pressure on the optic nerve.
Right.
So if you think about the optic nerve taking the message back to the brain, it's a bit like if you bump your nerve. It's just not working properly. Now visually, that can initially be problems walking from a light environment into a dark room, adapting. And then it often is quite insidious. It starts slowly, and then eventually it's like a cloud. And you won't always perceive the visual field change, which is the closing of the visual field per se, but normally you'd experience it as blurry vision, and it would be what we term intermittent, so it would vary from different time and different times in the day.
Yeah. Well, let's stay on that a bit. I mean, in that clip, we heard that Refugio lost her sight in the one eye. What's the normal course of events, and why does it end up, with blindness?
So typically when you lose sight, your first port of call is a local optometrist, and their job is to do what we call refraction, and that's trying to correct the vision with glasses. Now, because the problem is pressure on the optic nerve, the glasses won't work.
Right.
So typically what happens then is that they would need to be referred and then checked by a specialist. And we would have various things that we would look for. So primarily we look at the vision. Often the central vision is the last to go, but the first to really change is the outside vision, the peripheral vision. And that we have special machinery which is computerized, and that measures the sensitivity on the outside of the vision.
Let's just then come back. I mean, take us through the clinical course. I mean, we've focused on one aspect, vision, and what else happens if this condition is untreated?
So but first I would like to just continue and finish off of the clinical symptoms, because they do have a variety of symptoms, and some of them are actually neglected because you don't know what to make of them there. But I just mentioned the most common one as being a headache. They have other features as well. Sometimes they can have drop attacks, they can have tinnitus, they can have problems with the cognition, being forgetfulness, and this is often just say, oh, you're getting old, or you have too much in your mind, or it's stress.
For the sake of our other viewers, tinnitus means ringing in the ears,
so
right?
There's ringing in the ears.
Okay,
so they can have a variety of symptoms from that. It's not just particularly, but the most common one is headache and visual deterioration with that. But they can have a variety of them from that. The clinical cause of it, well, this condition has a variable natural history, meaning it's not the same for different patients from that. You have different types, or they are subcategorized basically into 4. You have patients that worsen and deteriorate, and patients that progressively deteriorate, and you have patients that deteriorate rapidly and then stabilize and improve. So you got a variety of patients. Just like my colleague Rob was saying, is that you can have patients that have now blurred vision, and a week later they don't have those symptoms. But the most important thing about the headache and the visual problems is that it's progressive. It's different how it progresses in different patients, but the notable thing that it is progressive. The headache does not go away. The vision keeps on getting worse despite you taking analgesia, going and getting glasses. It's progressive. So that's going to be a warning sign. That's the most important thing. Otherwise, it will not have enough time to cover all the variety of symptoms. It is the most important ones.
Yeah. And the prognosis generally?
So the prognosis of it is actually variable, just like because the natural history is variable. But the most important thing is that you can have significant morbidity. About 25% of this patient can actually have significant visual loss to a point whereby they can become blind.
Right.
So 25% is a significant figure.
Yeah, right. So I'm going to call you gentlemen back to talk about treatment, because for now we just want to, connect with the people living with this condition. Okay, time for another quick break. When we come back, we continue our discussion on IIH. Please stay with us.
Goodness is everywhere. It's the little things you say.
Please and thank you.
It's happening here. So helpful. And here. Oops. And is it the perfect family breakfast? Wheat Bix.
I'm not justifying apartheid in any way whatsoever.
But why can't you agree with that? Because it did wreak havoc to millions of South Africans.
It did. And I apologize for that.
He actually did not know that there's a convention declaring apartheid a crime against humanity.
The General Assembly labeled apartheid as a crime against humanity.
There's a difference between calling something a crime. Like genocide is a crime. Apartheid cannot be compared with genocide.
He was making a very narrow comment.
It's not only a crime against humanity, it's actually a sin.
It's an unrepentant apologist of apartheid who is not willing to accept that apartheid was crime against humanity.
I profusely apologize for that.
Public Protector Mosisiwe Mkhwebane's fitness to hold office is currently under question.
It's about the comments that was made by the court. Istina matter. She didn't investigate that matter at all.
Advocate Thulima Dontsela has previously said that she doesn't want Ms. Mkhwebane to be judged on the work that she did. We can't get away from that inevitability, can we?
I think she's being judged on her performance in office and the number of cases that have been taken on review that she has lost. She keeps challenging and appealing these decisions and keeps losing in all of the courts in the country. And it is on that basis that she's being judged.
She made it possible. I would not have wanted her to be judged that way. Let's be fair to her. Let the process not only be fair, but be seen to be fair. And let her just calm down and chill and allow this process to run its course.
Entrepreneurship is our business.
First month I made 100,000. I came up with specials, ideas. I'm like, I'm gonna make money. I'm gonna make a hell lot of money here.
Intentionally supporting your journey.
It's billions of money that are saved through stock trust. But this time around, we want to take those billions to build an economy.
Giving exposure to simple yet unconventional ideas.
We formulated this product for me and my brother for our beers to look the best version of themselves.
Helping to develop and sustain a thriving SME sector. This is our end goal.
I say I assist entrepreneurs to buy back their time and their sanity.
You get to network with like-minded entrepreneurs.
And our motivational quote for this week is from an unknown source, and it reads, "If you don't have big dreams and goals, you'll end up working for someone else that does."
This is SME On Point, and I'm Diabo Seto.
The doctor wanted to observe her for 6 months. Thus, she was ordered to stop working during that period. Later, she was ordered to stop working completely.
It affected me so bad to a point where my neurologist at that time said, "You cannot work further." And I'm like, okay, I mean, how am I supposed to survive if I can't work? I have to work. And with the pressure given on my brain, she said no.
The impact of living with IH can be daunting, and for people like Refilo, they are restricted when it comes to taking medication.
We cannot use certain medications for our headaches. So it either makes us relapse having a more painful headache than what she just had like a couple of hours ago. So for me, I would lie. It's either still pain, the tablets. I don't know if they're good for me. I wasn't advised on that.
Refilo suffered from depression due to her eye condition, which made it difficult for her to fully live her life.
I'm still healing till today. There's no healing given at that time frame. There isn't. It's not possible. I went for counseling. I tried hiking, I tried being with my friends, I tried to do something that's just out of the ordinary to try and keep my mind off what I'm going through.
Growing up, she remembers living a normal life without any eye problems. Thus, she had to ask her doctor what could have been the underlying cause.
There is no specific thing that can actually say, look, you've got IIH. There isn't. The only two things that I was told is to lose weight. Lose weight. And it came with a whole lot of lists after that.
Participating in a group provides one with an opportunity to be with people who are likely to have a common purpose and likely to understand one another. Refilo is also part of a group consisting of IH patients.
Me being part of this group, I'm just going to support the other ladies as well as myself, and also give awareness that there is such an illness as IIH. It's a silent killer. No one knows about it. You can think it's a small headache. No, it triggers more than that. So we want to try and help and raise funds the best way we can for ourselves, basically people with this condition, to get a job or to finding a treatment for this.
If you've been diagnosed with IH, it is important to know that this illness affects everyone differently.
All right, to learn more about the impact of this condition, IIH, we welcome back our guests, Kelly Duplessis, founder and CEO of Rare Diseases South Africa, and of course, Marika Thompson, herself living with IIH, and ambassador for Rare Diseases South Africa. And we're joined now via Skype by Melanie Victor from a hospital. Melanie, welcome to Health Talk.
Thank you very much.
All right, thank you so much for
thank
making.
you for this opportunity as well.
All right, thank you so much for the time that you've given us. We understand that you're in hospital, and we're not going to keep you too long.
Okay.
But perhaps let's just stay with you. We've been talking about this condition, IIH, or Idiopathic Intracranial Hypertension. And just give us a sense of what you've experienced with this condition. You've been living with this condition for some time now.
Yes, I've been diagnosed in April 2017. And since then, for the past 3 years, I've probably spent over 200 days in hospital. And so, I'm currently here at La Flora, based in Roodepoort. And they have become like a family to me. But it has a huge impact on, not just on, you don't just have those symptoms, it has an impact on your whole body, your emotions. I have been diagnosed with bipolar as well. And due to all the lumbar punctures, the nerve from my back to my bladder has been damaged, so I have to actually self-catheterize as well. So it has a ripple effect on your body once you get diagnosed with it. I got my shunt last year, June.
Yeah. You mentioned that you've had to be hospitalized a few times. Do you know why?
Most of the times it was because of the headache. Because the doctor wanted to do lumbar punctures and see what's going on, what's the pressure. Then later on, the doctor, he also said to me, you need to lose weight. You need to prove to me that you go blind, and then we will help you. So the treatment was only lumbar punctures and medication, but it didn't work, it failed. And then eventually last year I got my VP shunt.
Well, you said something about being blind. Just repeat that for us.
I have not, the doctor first wanted me to prove that I go blind. But the thing is, you get IIH with palpedemia and IIH without palpedemia.
Right.
And I have the one without eye problems.
I see. And how has this condition impacted your social and occupational life? Are you employed? What do you do?
I am currently employed. I'm a teacher.
Right.
But it does have a huge impact on the kids at school because I'm constantly admitted to hospital.
Right.
And then the thing is, because people in the beginning, they come and visit you, and because shame now you are sick. But every time you get into hospital, the people that visit you gets less and less. I've actually lost a dear friend of mine due to this disease.
All right, so you mentioned you have a VP shunt, and we'll explain to our viewers what that is later on. But what's the reason for your hospitalization now?
I have been diagnosed last year with iron deficiency anemia. So we had to sort it out, and then I've got admitted again now for the same thing. But tomorrow I'm going for surgery, and the iron deficiency will be sorted out.
All right, okay. Sure, yeah. Thank you so much for your time that you've devoted, to this program, and we wish you well going forward, and all the best.
Thank you very much.
All right. We're back to our studio here in Joburg, and to speak to our other guests. But before that, I believe we have a caller on the line, Madlalisa from Free State. Madlalisa, welcome.
Yeah, how are you?
We're good. How are you?
I'm good. Yeah, but I think they are regarding the I think they are the different IHH and glaucoma.
So you're calling about the condition, and you said something about glaucoma. So the line isn't too great, yeah?
I want the difference between the IHH and the glaucoma.
Excellent question. Thank you so much. We're going to give that question to the experts, the difference between glaucoma and IIH. Thank you for that question. Let's come back to you, back here, Kelly. We're talking about the impact of rare diseases just in general. We're going to come back and speak to her about, IIH. But, I mean, you don't have a rare condition except that your child does. But you obviously come across a whole lot of people in the organization that, that you support. Just give us a sense of how rare diseases impact people.
If I had to sum it up into one word, it would be fatigue. And I think what Melanie was just saying now on the line is so critical. This is a marathon journey. And, the difference, I think, between rare diseases and a lot of the more acute conditions, you can, if you have a massive trauma or you get sick with something, or even cancer patients, often, you're going to have to go for treatment for about 6 months or a year. They give you a kind of time frame. Rare diseases, you don't know if it's going to be 5 minutes, 5 days, 5 years, 50 years. So planning is quite a challenge. And you have to, as a parent, I think you grieve the child you thought you were going to have. You have to accept the child that you get in their place. I think as a patient, as an adult, exactly what Melanie and Mareka were saying earlier, you have to go through, your life is not what you thought it would be. And planning with a chronic condition is very difficult. And you get tired. The exhaustion is common amongst all of us, regardless of what condition we're impacted by.
Yeah. So earlier we spoke about how specialized the treatment is, if available, for some of these conditions. Can you just comment around access to treatment for people living with these conditions?
Access to treatment is very difficult in this country. We're faced with lots of different issues. One, obviously diagnostics and accurate diagnostics are necessary before implementing any treatment, because you need to know you're treating a patient for the right thing. Our disease burden in terms of costs is huge. Many of our conditions have very expensive treatments, and a lot of them are biologic treatments and innovative drugs. So you're looking at 3 million rand a year for a patient. That's lifelong costs, so it also doesn't go away. It's not like you expend that expense now and it gets better. So that makes it a challenge as well. You've got the dichotomy between the state sector and the private sector, and there's this perception that in private sector it's so much better. It isn't, because prescribed minimum benefits revert you back to what's available in state. So everyone initially, all the industry players really started working on the private sector, trying to get access in the private sector because they thought it would be easier. I think we've realized in hindsight that was our biggest mistake. We needed to do more work in state, because if we can get it right for state patients, it'll ultimately carry through across the sectors.
Absolutely.
So access is a challenge. And, I think for me as a parent, then that was one of the reasons I started this organization. My son's treatment had just become approved at the FDA about 2 years before his diagnosis, so it was very new. It had not been made commercially available in this country. And the doctor said, it is available outside of South Africa, but not here. And I was like, well, can't we just get it here? I didn't realize the processes that was involved.
Yeah.
And so now we're really active. If there's one patient in this country and there's a treatment out there, I will do my best to make sure that they can get their hands on it, because they deserve that.
Okay, Marika, let's talk about you now, your personal experience with IIH. When were you diagnosed with this condition?
Sorry, I was diagnosed in July 2017 after misdiagnosis. The physician that I first saw, they admitted me mainly for meningitis, because that's what they thought it was. And then I got to see an endocrinologist, because the MRI scans and everything he did showed that the salotocisa is actually fluid-filled and the pituitary gland is flattened. So where does this fluid come from, was the endocrinologist's question. If there's fluid in that cavity, where does it come from? Right. And she actually insisted on seeing the neurologist. And when they did the LP, it's very sore. I wish that upon no one.
The lumbar punctures.
The lumbar punctures. But unfortunately, that is our journey.
Right.
And then my first pressure reading was 48, which is very high. I know the experts can tell you more about that. And then they got the diagnosis of IIH. So I've been on medication. But the memory loss and the blackouts changed my life, and due to the high pressure and the fluid on the brain, then that's where I went for a second opinion with a neurosurgeon, and he said due to the memory loss and the high LP readings, we will have to do the shunt, otherwise you will end up going for LPs every second week. And I didn't see a chance for that, but due to the empty cellar syndrome that I have with IIH, there's a lot of factors that's playing another role as well, like the weight gain I had. When I was diagnosed, I did not weigh what I'm weighing now. So it's this misrepresentation of who you are when people see you. Because we don't want to feel the way we do. We also just want to have a normal life. And having a misrepresentation of, you've got a headache, go lie down and take 2 Panados. I wish it was that easy. I really do. So there's a misrepresentation of what we are going through as individuals.
Right. And how has this impacted your own social, occupational,
Well, it definitely I went from being all social and available, you now get your days as I'm not feeling good, I can't do this today. So it has a huge impact on your life. And what is upsetting me, the reason why I don't want to show my face in public anymore, is because people say, have you tried weight loss? That is one of the most common questions we get, is have you tried weight loss? Do you think I tried to gain weight? That's not the story. And there's people that's diagnosed when they are skinny, when they are not obese, and due to the empty cellus syndrome. I gained weight. I am in and out of the dietitian's office. I'm in and out on medication from the endocrinologist. But it is sad to think that is the impact on our
Marika
lives.
Thompson, thank you so much for your time, and I can only wish you the best going forward.
Thank you.
And Kelly, thank you so much for sharing all this information with us, and all the best with the organization.
Thank you very much.
Well, time for another quick break. When we come back, we now focus on treatment for this condition, IIH. Please stay with us.
Taking a look at how the youth consume news.
I prefer using social networks for information.
I happen to find reading news on my cell phone more convenient than reading news in newspapers.
I do follow various news sites there, and I get the links to the news articles that I read every single day.
I prefer using the net to watch to get the news because of it's convenient.
Watch Media Monitor Sundays at 9 a.m.
Public Protector Mosisiwe Mkhwebane's fitness to hold office is currently under question.
It's about the comments that was made by the court. Istina matter. She didn't investigate that matter at all.
Advocate Thuli Madonsela has previously said that she doesn't want Ms. Mkhwebane to be judged on the work that she did. We can't get away from that inevitability, can we?
I think she's being judged on her performance in office and the number of cases that have been taken on review that she has lost. She keeps challenging and appealing these decisions and keeps losing in all of the courts in the country. And it is on that basis that she's being judged.
She made it possible. I would not have wanted her to be judged that way. Let's be fair to her. Let the process not only be fair, but be seen to be fair. And let her just calm down and chill and allow this process to run its course.
Welcome back. If you've just joined us, we're talking rare diseases with a focus on IIH. And with us is Dr. Khomotso Hlahla, neurosurgeon, and Dr. Rob Daniel, ophthalmologist. Now, before we start talking about treatment, we have Cynthia on the line from Cape Town. Cynthia, welcome. Cynthia, are you there?
Yes, I'm a journalist.
Hello, Cynthia. Do you have perhaps a question or something to share with us?
I have a question, doctor.
Sure.
I usually get headaches.
Right.
They come and go.
Right.
But it starts so low and then it gradually becomes severe.
Right.
And I feel the pain mostly on my right eye.
Right.
And it's so severe. And when taking tablets, it doesn't go away.
Okay.
And what happens, what makes it better sometimes, I would lie down in a cool, dark room.
Right.
And it will go away on its own. Or maybe I will end up vomiting.
Uh-huh.
And after I vomited, it just disappears.
All right. Have you seen a doctor about this, Cynthia?
Yes, I've been to the doctors. What they do, they normally just give me pain tablets.
Right.
And the other thing, my eyesight, it's becoming poor. I can't read the book.
I see. Okay.
So I'm wearing now reading glasses.
All right. Okay.
And the last time the optometrist told me that there is pressure on my right eye.
Right. Okay.
Yes.
Cynthia, thank you so much for a question. We'll put them to the specialist, and we hear what perhaps advice you get from there. Gentlemen, it's firstly, obviously, here's the question from Cynthia about persistent headaches that get worse, and now she's got blurred vision and so on. But we also had a question earlier about the difference between glaucoma and IIH. Anyone can.
I think it's a superb question, simply because glaucoma is one of the most common diseases.
Right.
It's the second commonest cause of blindness on earth.
Right.
And it is irreversible, and it does not have any symptoms. That's very important. Cataracts are the most common cause, but we can fix them.
Right.
So they're not a permanent cause of blindness. But glaucoma, because you don't feel it, you don't know you have it, it causes blindness, and one day you just wake up and you're blind. So we have to check you for it. The fundamental difference between glaucoma and IIH is pressure on the brain that is transferred to the optic nerves. So it's more a neurosurgical etiology or cause, whereas glaucoma is within the eye.
Right.
Now, we used to think that it was pressure in the eye, but it's only pressure in the eye 70% of the time. And that happens because various reasons. The drainage doesn't happen well enough, but that causes damage to the optic nerve from inside the eye.
Inside the eye.
And that also causes a visual field shrinkage. But it's definitely not a rare disease. It's one of the most common diseases, and you must be checked for it.
Excellent question, I guess, All right, so the second question, this young lady, well, I presume that she's young, persistent headaches, now starting to affect her vision. What would you advise?
I think, as you correctly asked, if you have seen the general practitioner, that's usually the first line of defense. And if the symptoms persist despite the medical treatment, then the next thing will be to a specialist referral from that. So people that normally see headaches in general, those will be the neurologists from there. So they can either refer to a neurologist. Now, she also complained of visual problems. So like Rob said, they will initially see the optometrist, just like they'll see the general practitioner, and then they get referred to ophthalmologist. So she must have seen the general practitioner, she must have at least seen the optometrist, and at this point in time, if it's chronic, if it's persistent, she might have seen the ophthalmologist. By the time you get to the ophthalmologist, a diagnosis will most likely be made, because if there's pressure on the eyes, per se, the ophthalmologist will be able to pick that up, and they will refer. You cannot make a diagnosis. What you can see is that there's symptoms that you have increased pressure in the eye, and then you have to refer either to a neurologist or a neurosurgeon to investigate further what is the cause of that. Obviously, if it's not from the eye, like Rob says, if it's a result from the brain, the central part causing transmission of that. So she must have seen those people.
Central message there is that, Cynthia, please, if you're still watching, please go and see your healthcare professional, and of course, if the symptoms persist, please insist that you get referred on to a specialist. All right, let's come back to IIH now and the treatment. Let's talk the principles, first of all, of treatment.
Okay. The most important thing is to make a correct diagnosis.
Right.
That's the most important thing. And that usually is a multidisciplinary approach. You need the neurologist, ophthalmologist, neurosurgeon from that. And they make a collective diagnosis from that. Also, obviously, with the radiologist as well. Once the diagnosis is made, and the most important thing, you have to meet the 5 diagnostic criteria. And the reason why the diagnostic criteria is that to exclude false diagnosis. So you need to meet that criteria. Once that is met, and you categorize the patients according to the symptoms, whether they're mild, moderate, or severe from that. Obviously, they continue seeing the neurologist, ophthalmologist, and they continue getting checked to see if they're deteriorating or not. If there are mild symptoms, like say it's a mild headache, it doesn't disturb significantly with the quality of life, the vision is not impaired or not significantly impaired and it's been tracked, it's constantly not deteriorating. Those are patients that you can treat conservatively from that medical treatment. But it also depends. The most important thing is from a patient's perspective. What do they feel like? Are they able to tolerate it? Is it affecting the quality of life? So if they're classified as mild, then the management is mostly conservative from that.
Right.
And if the patient is mild to moderate, that's the other thing, important thing is the vision. The vision and the quality of life. If that's significantly impaired, then you can start institution medical management. Those are the drugs that we talked about, the Topomax, the Diamox, the several drugs.
So talk about vision, Dr. Rob. where do you come in here? I mean, what part do you play as an ophthalmologist?
So the first thing is that working in a team with other doctors, we able to look at the optic nerve in 3D. So we can actually see it coming towards us. So in a hospital setting, we'll be often asked to look and see if we think the optic nerve is swollen. More importantly, our main function is to convert vision into numbers. So we measure the central vision and we give you a number, which we all know 20/20. That's a Snellen chart. And then we measure peripheral vision, and that's a little bit more complex. There you respond to light, and a computer works out how much you can see in the outside of your vision, and then we have a number. And that number normal would be 0, and then we pass this result on to our neurosurgical colleagues. So if it's say -2 to -7 decibels on the peripheral field, we would regard that as moderate. And if it was more than -7, then you probably need some more intervention. So that we work together to help each other make these decisions.
All right. Before we run out of time, I don't want us to run out of time before talking about those VP shunts. We've heard a lot about VP shunts. At what stage should a VP shunt be considered, and what is it, by the way?
Okay, a VP shunt is a ventricular peritoneal shunt. So essentially what it does is that it takes the fluid from the brain and it shunts it and diverts it to the peritoneal cavity. Everyone has that fluid, amount of fluid, is cerebrospinal fluid. So you're bypassing the normal pathways from that. It is, the theory behind it is that by draining that, you decrease the amount of pressure. If the amount of pressure is decreased, there's less pressure on the eyes, so the headaches improves and the vision improves as well. So you will do it once the patient has significant symptoms from that. So if we're at the point they have significant symptoms or medical treatment has failed, or their quality of life is significantly impaired, such as what we saw in the video on the clip.
Okay, so surgical treatment is the last option, so to say.
It is.
And in general, treatment does impact quality of life positively.
Yes.
Okay. Well, gentlemen, thank you so much for your time.
Thank you.
And and to you folk at home, thank you so much. That's how we come to the end of the show today. We're back with you again in a week's time, same place. I'm Dr. Selomot Daung. Until then, please do take care.
It's time to give hope with Cancer Shave-a-thon 2020. Go to your nearest participating shopping center on 29 February. Shave, spray, or donate your hair in support of cancer survivors. Get your workplace, school, or sports club to host a shave-a-thon from 2 to 6 March. For more information, visit shaveathon.org.za or call Cancer toll-free on 0800 22 6622. This is an SABC Foundation-supported initiative.